Welcome everybody. My name is Damian Shield and I'm the Senior Director at the Institute at the Center for Medical Simulation, and we're an independent nonprofit focused on patient safety and simulation-based education in healthcare. We do training locally and instructor courses internationally, and during this COVID pandemic, we enacted this weekly webinar series to connect with all of you colleagues across the globe. I'm so pleased to have Dr. Saša Sopka here, a colleague and friend. Saša will introduce himself a bit more thoroughly, but I'll just say that I know him to be a caring clinician and father and educator and administrative leader at his institution. I've had the pleasure of working with him and connecting with him in 3 continents, here in Boston, where he's been here with us at CMS, as well as the Harvard Macy program, in Australia, where we got a chance to brainstorm and cook up our joint collaboration between the Center for Medical Simulation and AIXTRA, the simulation program at RWTH. And of course, I've gotten a chance to visit him there in Aachen. So without further ado, Saša, welcome, and welcome to everybody. I'll let you know that my role will be to moderate the comments. So we're going to invite you to participate throughout the conversation today by clicking into the Q&A. The Q&A, questions and answers chat box, is there for you to interact with us. So do go ahead and use it both to give comments throughout the session as well as to ask questions. I'll be moderating those comments and bringing them live to Saša so he can respond and react to your comments. And we'll be stopping the presentation a couple of times to do that. I connected with Saša asking him to talk about this topic, which is he's quite passionate about. And we thought that at the end of the session, we're hopeful, at least for me, that I'm going to understand the problem of the complexity of the interactions of managing different parts of the health system, and describe how structured communication and checklists may improve patient outcomes. And he insisted that we put it with a question mark. And so I'm very excited to learn from Saša and with you all over the next hour. So I'll stop sharing my slides, Saša, and hand over to you so that, explicitly hand over to you so that you can introduce yourself, your program, and what you have planned for us today.
I'm not quite sure if we were talking about which checklist will we use for the handover, maybe. So maybe you have a suggestion, I'm not quite sure. Thank you very much, Damian, for these very nice words. I'm pleased to be here. I'm pleased to be invited. And I'm starting to share my screen so you will be able to see over the next probably 25 to 30 minutes the different topics I would like to address here. And as I said before, thank you, Damian, for inviting me. Thank you to the CMS for this long-term collaboration together and for having the chance of learning together, exchanging information with a worldwide network. I'm really pleased to be here, and I'm also pleased to having sometimes in life the next cappuccino in Brisbane together with you and exploring great ideas. So thank you very much. And I'll let you know a little bit about my institution where I'm working. So I'm starting with the introduction of my institution. I'm working in Aachen, that's in Germany, very close to the border to the Netherlands and to Belgium. And our hospital is a university hospital covering all of the medical fields, what are very well known to you. We have approximately 1,400 beds. We are, in Germany, we call that a maximum care provider. We have 36 specialized clinics, over 50,000 inpatient cases or contacts, and over 200,000 outpatients per year. We have over 8,000 employees, and everything is concentrated almost in one building. That's maybe very special if you compare the situation to other German university hospitals. 90% of all the activities and of all people are just in that one building. And as exceptions are always confirming the statement, The training center, what I'm directing, is in this building on what you can see on your right side. We are a professionalized training center and a center for patient safety. We have different simulation rooms covering the topic for many years. And with a few employees, we are trying to improve care in Germany and in Aachen. A little bit about my person. I'm an attending physician in anesthesiology as a specialist of anesthesiology, intensive care, and emergency medicine, working probably over 15 years, 16 now in the healthcare system in Germany. I have a master's degree in medical education, and I'm responsible for different areas of education, training, and patient safety at my hospital and on national level here in Germany. And I declare that I have no conflict of interest by being financed of pharma industry or something else for that, what I'm talking about today. I'll give you a short overview over the next 25 minutes. In the introduction of the topic, I will talk a little bit about the importance of patient outcomes related to patient safety and the human factor, bringing up the topic of complexity in healthcare or of the healthcare systems. And we together, and I'm inviting you very much, I hope that we can talk over this digital medium about checklists, algorithms, and interactions, and what the meaning of them as elements is to patient safety and to patient outcome. After the discussion of the first part, we will focus a little bit more in detail on checklist and evidence, what's existing in the literature. Then we will discuss about that. And the last but not least topic will be structured handovers. And probably until then, Damien and I will agree about which protocol we will use and what the discussion will be. So these are the next minutes, and I'm inviting you to this ride in the topic of patient safety. So if we look at the topic, what the WHO analysis said about Europe and patient safety aspects in the system, probably 1 of 10 patients is harmed in Europe. That's the statement of the WHO, is harmed while receiving care. It's a very neutral information. 43 million patients or 43 million incidents are occurring every year in Europe. And the costs of what happens related to medication errors are calculated by the WHO by 42 billion US dollars annually. And this is, for me personally, pretty impressive. So I was very curious to look a little bit deeper into that information. And there were more statements what are really shocking me, that if you analyze medical errors in hospitals or in healthcare providers, institutions, and adverse events, in 8 to 12%, different sources are saying different values, but somewhere in between 8 to 12% medical errors and adverse events occur while the patient is in hospital. If we would apply more strategies to reduce adverse events only in the EU, we could prevent more than 750,000 medical errors, prevent around 3 million hospital days, and we could probably prevent over 90,000 deaths per year. And this is, it tells and it stands for itself. And comparing this to the German situation, I'm showing a slide from the German statistical authorities, what's published in 2020. And unfortunately, it's in German, but I will translate that for you. It says that we approximately have around 1 million of deaths in the healthcare system per year, and it analyzes the causes of deaths. And as you would probably expect, the cause of death number 1 are cardiovascular diseases, cancer on the 2nd place, trauma and other things on the 3rd, and on the 4th place. But wait a second, we were talking about approximately 10% of deaths, as I mentioned before, per country in Europe were 100,000, approximately 100,000 deaths caused by medical errors. And we are not seeing them here in this classification. And this is something what's very important if we are analyzing patient safety related issues or issues to medical errors caused by the human factor. There is a study of Professor Macquarie and Daniel published in the British Medical Journal in 2016 and that analyzes the situation in the US. Interestingly, it seems to be the number 3 of caused deaths in the US. So medical errors are responsible. This is what the study is telling us. Medical errors are responsible for the third, so so they are responsible for the third leading cause of death in the US. And I think this is very impressive if we are talking about intervention, how to improve care, how to improve patient outcomes. And the study is very interesting. It shares details about where this data is coming from, and it says something that the Institute of Medicine report from 1999 in the United States is talking about approximately 50 to 100,000 deaths annually caused by medical errors. Later on, the same authors published a few studies and a few analyses that probably even more deaths are caused by medical errors. And this is something what we have to mention if we are talking about using checklists, addressing complexity in medicine. So if I'm sharing something about challenges in the healthcare systems, we cannot ignore the following topics like demographic trends. In Germany or in Western Europe or worldwide, we have an increasing number of elderly patients, and these patients are becoming usually more complex to the system. On the other hand, we have another factor what is responsible for complexity in healthcare, and this is the information quantity. If we are mentioning big data, and I think this term is not very well describing what we have, but we have so many information in the healthcare system, and it's so complicated to apply this information in a proper way to improve the patient outcome. We have the healthcare system costs, economical aspects, what are influencing human beings as medical experts. We have the complexity of the system and the qualification of people, and we have multi-professional and interdisciplinary collaboration as a topic, what challenges the healthcare system and what challenges good care, as we are probably not always trained, not in every country and not in every system, also in a multi-professional and interdisciplinary manner. So this could be a challenge to the system. So if we just turning to the human factor as a cause of errors in medicine, unfortunately, we will not. It will not happen that a human becomes a machine and that a human will not make errors. So if we know this, it would be interesting which aspects of human factors are maybe responsible for medical errors and how can we address them. I identified a few areas like communication, decision-making, teamwork, process management, technology control. I hope that we still have the control of the technology. But if we are talking about technology control, it's also offering challenges, how we can keep the control and how can we be good enough to control technology, not to make some medical errors, and how to apply knowledge in complex environments. This would be the aspects. And if we have identified areas who are maybe responsible for medical errors and who are maybe causing deaths of our patients, what we have to avoid, what we have to take very, very serious and not ignore these things with statistics who are not describing these causes of death. We have to ask ourselves the question, is medicine so special? Are we the only discipline who is handling with these challenges, and can we do something? Or can we maybe see similar problems in other areas? Can we learn from someone else? And for sure, as I'm guiding you, there is an answer. What can we learn from aviation? That was my question, what I had to myself. And at the beginning, I would like to describe situation occurring maybe 3 to probably 4 months ago. That was on the right side, this airplane, an Airbus A320, what crashed on the 22nd May in 2020. And it was somewhere close to airport. Unfortunately, almost all passengers died. And by analyzing the situation, why the airplane crashed down and caused so many deaths, what maybe were avoidable, usually there is analysis of a situation. And what they have seen analyzing this air crash was that the landing gear was still in retracted position in the moment the airplane was trying to land the first time. And from this point, I, as a non-expert in aviation, don't have the clear information, but there are some suggestions what could happen. And there are models in aviation who are analyzing these accidents. And Scheppel and Wiegmann, who are experts, US experts for linear accident analysis, like HFACs, they're often bringing up topics like complacency. And honestly, I have to tell you, I was not aware of this word and of this term in English. So a very good friend, pilot from Lufthansa, who is also a psychologist, and as I mentioned, a very good friend of mine, he explained me that the situation of pilots in which they are is often that pilots are doing a boring job. And not at all. So not the whole job being a pilot is boring. No, not in total. Please don't understand me wrongly. But there are some procedures and some moments and processes where you have to handle a very easy handling situation with many tasks, and you have a high routine. So in this case, or in these situations, people become unaware, and they become negligent to that what happens. And one assumption, coming back to the airport crash from this Pakistan Airlines 8303 crash, is that maybe the pilots just forgot to activate the gears for landing, and this caused many other things. And at the end, unfortunately, in the second attempt, a landing what was not good. So what can we learn from aviation? What we can learn is, if you look at the illustration on the right side, at the graph at the right side on the monitor, what we can see from the 70s, probably we had less than 300 million passengers in the world flying by airplanes. What we had, on the other hand, was more than 1,500 deaths in aviation. And moving through that time until today, we have today probably more than 4.5 billion patients in aviation flying every day, exceptionally in Corona times. And we have only in 2018 and 2017, probably something like 200 to 400 deaths per year. And this is not just happened, or that not happened just by occasion. This is just happening because aviation is taking very seriously human behaviors and human factors, and they are training people, and they are adapting checklists, and they are using structured protocols and handovers for making aviation safe. What we are missing are sometimes transferable studies and reliable data just to apply this knowledge to medicine. An interesting book is the Checklist Manifesto. Probably all of you who are here read that book, or probably many of you know about this book. It's written by Atul Gawande. It's a surgeon from Boston, working on the Harvard Medical School. I know that he's an endocrinology surgeon, and he is talking in his book about the using checklists in medicine. And he entered many personal experiences and a lot of his very well conducted research. And he identifies a few principles what cause failures in medicine, like ignorance or inaptitude. And making sure that that not happens, he's saying that applying checklists to medicine makes medicine safer. And you will follow his thoughts very easily and very interestingly. And I just can recommend this. And this book is also describing that there is a high resistance of, especially unfortunately, physicians to apply checklists. And we will look at this more detailed over the next minutes. What else can we learn from aviation? Well, we can learn that probably more than 70% of all reported incidents are caused by the human factor. So what happened in aviation, I was mentioning that before, is that mechanical errors are almost today very low, probably not even more than 5 to 10% of the cases are caused by mechanical errors, and the most of the errors are caused by the human factors. And there are different strategies what aviation is applying to its system to increase safety and to avoid errors. And on the institutional level, I would assume that aviation is probably 30 to 40 years ahead of us. And we have to identify that aviation is probably a little bit another field what has a few similarities where we can learn from. If you just explore, for example, that IATA white paper, you can identify a few areas what are important for improving safety. And these are areas like safety awareness, senior management commitment, communication, culture, learning organization, management commitment, policies, processes, and procedures, reporting and feedback. And I will say, and I will try to show that many of these experts and many of these areas are probably covered with using a checklist or a structured handover. So almost at the end of the first part, my suggestion is, and the suggestion from the literature is, that many checklists, what we know, are very helpful to improve care of our patients and could avoid medical errors. Two examples, what I'm showing here. One is the ABCD approach, what could serve as a checklist by providing emergency care to the patient. On the other hand is the surgical safety checklist from the working group from Gavande. What has shown by publishing it and doing that research and publishing it in the New England Journal, evidence for reducing medical errors. So I'm inviting you to a short break to discuss the topic with me, and Damien will probably now take over and moderate the discussion. And I hope that we maybe have also some input to the questions, to the Q&A, what we can talk about or answer.
Thank you so much for your presentation so far, Saša, and bringing this idea of complacency and boredom, because I usually think my job is pretty interesting, but bringing those two topics up makes me think it would be very interesting to think about what might be moments in our work for those of you who are clinicians or who have spent significant time within health systems to be able to kind of help us think through specifics. If you don't mind putting in the Q&A, moments in your work that you think are high risk for complacency or potentially boring. And for me, I'll start that lens of, is it boring or am I just expecting it to go well? Makes perfect sense. Like discharging a patient, which I know is high risk, is potentially pretty boring. Handing off a patient into the hospital or to the oncoming team, I feel like the interesting part of the work is already done. The handover is kind of secondary. So I could see that psychology in play. I'd love to get a few comments from the audience in terms of how you're making sense of what Saša is presenting. And if you have any questions about what he said so far that you would highlight for it. and Sasha, I'll read here for you and so the other folks who are watching the recording. So interprofessional education and interprofessional care will definitely contribute largely to patient safety. What's the role of clarifying and communicating for interprofessional care? That's one question. I think that's very interesting because I think we generally think of professions as self-regulating. And so I could imagine different silos creating checklists for themselves and creating checklists across professions to be quite challenging. And someone else is saying, when the intensity is over, how do I, when I quote, know how to do it, is when it's easy to become complacent. So I think they are saying, yeah, once I'm no longer problem solving and I think I'm on the glide slope, to use an aviation, that seems like high risk. They don't give it a specific example, but I could think of, I know from my practice, I think I could think of the initial diagnostics as a more intense moment, but then once the plan is in place, it seems more straightforward. Do you have examples from your practice as an intensivist or anesthetist, Sasha, where you could say, okay, this is an easy area to become complacent?
Oh yes, totally. So if you think about the induction of anesthesia, I'm always comparing, as on the picture, so thank you for that question, anesthesia procedure with a flight. As we are starting the flight, one of the most critical points in providing care are occurring. And that's the same in aviation. As we are starting the plane, the start of the plane is one of the most complex situations where you really have to be aware. But doing it every day, or probably providing anesthesia, in my case, every day, and doing 10 inductions of anesthesia per day, I had many situations where I forgot something, even if it's totally clear. And I have to remind myself always, put a checklist on the board with very big written letters. Do not forget this, this, this. Have you prepared succinylcholine if you use it, or have you done this, or have you done this? I could talk about many situations where we forgot something because of that phenomenon called complacency. And I have to say, with the checklist, it would be more helpful. And also I have to add, if I would train myself, or if I would be trained addressing a checklist, also using the checklist, it would be even more helpful to me. So this is one part. And I think there was a question about communication interprofessionality, how we can maybe realize a better communication through a checklist. And I think the surgical safety checklist, I don't know if I understood the question properly, because if you were talking about silos, every profession or everyone is designing checklists for themselves. The best example was the surgical safety checklist would address a multi-professional team. And there are some topics in the checklist what are bringing in a profession like the nurses who had to say something, or have to say, like these speaking up moments. But if you have a checklist who's regulating that screaming anesthesiologist, I'm an anesthesiologist in the room, if he has to, sorry for the expression, shut up and let others speak, I think this is very helpful. And others could contribute with their observations of the situation.
So, Sasha, from the comments again, there's a participant that's saying, well, if I have 7 cases in the OR, I wonder if a checklist might be more useful early in the day when I'm getting into the routine, that's my editorial, more so than later. And to follow that up, they said, because sometimes going through the checklist itself can be boring.
Yes.
So that seems like a potential double-edged sword where you implement a solution that creates a new problem. I'll just give you 2 more comments and then I'll let you go on with your presentation, or not let you, but invite you. Monitoring stable patients under anesthesia risks complacency, yet demands the capacity to detect subtle aberrations. So I guess the question there is, to what extent how do you decide when to let things be or keep on checking? And another person says, sharing from a different domain says, if useful, in a rock climbing, a significant number of accidents happen after the climb is over, when vigilance drops. So he's curious how Saša modulates his attention across the day in the operating theater. How do you integrate that into some checklists? So I'll just hop off screen here and let you take those questions.
Thank you very much. So keeping my, being aware the whole day, it's sometimes really difficult by monitoring a patient. If you have just one operation over the day and everything seems to be good and the patient is just in a very good condition. In this case, a checklist could be very helpful. Maybe a checklist could digitally show up every hour or every half hour, and raising up the awareness by checking, is your blood pressure, your frequency, and your saturation still in your green level, so in the desirable level where it should be? Or have you checked the hemoglobin still? And maybe also a checklist with the question, asking the other profession, the surgeon, okay, are we still good? Is there any bleeding, what I maybe cannot see over the operation situs? These kind of questions would be probably helpful, but are probably still not addressed in the common checklist, but there are some of these aspects who are addressed. And maybe by presenting now a little bit more in detail, the topic checklist, you will see what I mean. So I would, if you allow, continue with the presentation by addressing the surgical safety checklist and the topics related to checklists in medicine. So if you see an example of the surgical safety checklist provided by the World Health Organization and composed by the Surgical Safety Initiative led by Atul Gawande and other people in this team, you will see a 19-item checklist. What is addressing exactly the situation in the hospital where the patient is just before the induction of the anesthesia, before the skin incision, and very close after the operation is finished. So we are capturing this moment where the patient is operated. There is a study published in 2009 in the New England Journal of Medicine, and I think this was the icebreaker. In my understanding, there are a lot of more studies who are talking and investigating the using checklists in medicine, but this study published in the New England Journal was really very important to the acceptance, and also saying something, providing data about how checklists are improving patient outcome and saving lives. So if you think that in the world, we have annually probably 234 million operations in the world. And these operations are really very important. Not only elective emergency operation, every operation is captured here under these assumption of 234 million. And if you hear that the half of the adverse events in these operations is avoidable, you really start to think, okay, I have to start now with using these checklists, and I have to compose or adapt the checklist directly into my environment. And I already provided you a very important information. Usually you have to adapt the checklist into your hospital or into your environment. That's the first step of how you do the implementation process of the checklist. This study conducted by Haynes et al. Was a worldwide study with over 8,000 patients. It was a WHO study supported by the WHO, and their checklist content, as I already mentioned, were the moments before anesthesia begins, prophylaxis against infection, effective teamwork. All this is in the content of the checklist use, so different aspects were captured with the checklist. The checklist had consisted of 19 items, and these 19 items are probably easier to fill out than another checklist with more than 100 items, what probably will not have the same compliance as a 19-item checklist. It's just one of the aspects. We had primary endpoints in the study. So there were major complications during the post-operative phase, including death, and the phase of investigation were 30 days. What were the results of the study? 30 days after surgery, they could detect a significantly reduced mortality and death rate. So the death rate was reduced about 0.7%. And this seems to be not too much. But if you think about these 234 millions of operations, and if you think about how many deaths could be avoided, it's something around 1 million deaths what could be avoided worldwide by using a checklist. And this is totally convincing to me. So with reading this in the study published in 2009, probably my hospital should have the checklist already the next day, but it's not so easy as it sounds. Rate of complications was also significantly reduced, and a tremendous number of complications could be avoided during operations if we would use a checklist. So still unclear after this study what was distributed over the world and provided in 9 different hospitals. Still unclear was what was the effect, what was really responsible for reducing the mortality and the complications rate. So the exact mechanism was not detected, and until the end, it's still unclear if it was due to the checklist items or maybe due to the increased awareness of making errors, what the checklist increased by just using the checklist. So you can find, if you're exploring the literature after 2009, more very valuable and very interesting studies. Here I'm presenting now the SURPASS study provided by De Vries et al. And published in 2010. It's a national study in the Netherlands, and the study was about, it was an observational study, what was targeting the entire surgical pathway. The authors of that study had the hypothesis that probably more than 50% of the complications caused while operation, or caused with an operation were occurring outside of the OR, so before and after the OR, and therefore they tried to address the whole process of the operation, so the whole perioperative process with a 124-item checklist. And as I'm telling you that someone is trying to establish a 124-item checklist, probably a few of you who are listening this and who were reading that study were thinking, okay, who the heck will fill out that checklist? So what the authors have done, they divided the checklist in different moments, and they used 7 time points focusing on different fields of the surgical pathway, and that was the way how the checklist was divided and accomplished. At the end, in the participating hospitals, many processes as a result were optimized. The primary endpoints were similar to the other study provided by Gavande, that were the number of complications and in-hospital mortality. And also in this study, the results of the surgical safety checklist could be confirmed. So the total number of complications decreased from 27% to 16.7%, and the hospital mortality also for 0.7%. And this was a strong confirmation for the study results of the study, what I was talking about before. And now we have even more pressure to use checklists while surgery is occurring. And all of these checklists are addressing multi-professional aspects, multiple layers of the whole process, and probably addressing many aspects you already brought up, addressing communication, addressing awareness of people, complacency, and different other things. Still not solved was the problem, is the checklist, is the usage of the checklist a black box, where we don't know, is the checklist itself responsible, or maybe the awareness what the checklist raises up for the improved patient outcome. And this study from De Vries et al. Gave a little bit more clarity about that. With reduced compliance to the checklist, the results were totally not the same. So if people were not filling out more than 80 or 90% of the checklist, the results could not be reproduced. So this is one of the very important conclusions of that. Annals of Surgery in 2012, a researcher group around Arnold van Klei published also a study, also using the WHO surgical safety checklist with 90 items. And they tried to investigate the aspect if the completion of the checklist is responsible for the improved patient outcome, or maybe the overall awareness of patient safety issues. It was also a retrospective cohort study, an observational study, and no randomized controlled trial. And as I'm bringing up that topic that this was no randomized controlled trial, you will also later on see what is still topic of the discussion, if this is enough evidence for using checklists everywhere, as it is still a critical discussion. In the Annals of Surgery study in 2012 from Van Klei, also the in-hospital mortality was the primary endpoint. 30 days after surgery, we had observed, or they had observed 25,000 adult patients. And also this study showed a significant decrease of the in-house mortality of the operation mortality from 3.1 to 2.8%. I'm not going deeper into the statistics, but you can be sure these results were verified and are representable. So this study, as a conclusion, identified that checklist compliance is probably the most important factor for influencing patient outcome. And addressing the topic, what we are talking about today, a very important take-home message is that using the checklist compliance as a performance indicator for multidisciplinary teams could really help in improving the patient outcome. Still unclear, even after the study, what is the relationship between mortality, post-operative mortality, and safety culture, as well as human factors. That was still not investigated and too complex for this study. One interesting thing at the end, or last but not least, one study, what is published in 2010 in JAMA, evaluated the application of, or the association between implementation of a team training program and surgical mortality. And why I'm talking about this, as it seems that this is a complete different topic. No, it's not. The team training program contained using of checklists, briefings, debriefings, addressing the communication in the OR, and addressed training and preparation of the whole teams as an interprofessional training. And what a surprise. Interestingly, analyzing the data of over 180,000 procedures, there was a strong evidence for reducing mortality in hospitals where this team training approach was realized and implemented. So participation of these hospitals to the medical team training approach resulted in lower surgical mortality rates. And with this, we have clear evidence for using checklists. So what to do now? The literature is more than 8 years old. Every one of us probably should now use checklists. Otherwise, we are doing something wrong to our patient. Isn't it like this? Usually I would ask you now this, but if I'm talking like this, unfortunately, there is another study in the New England Journal published in the year 2014, 2014. And it's about the introduction and application of surgical safety checklists. And the checklist, what was used is the WHO checklist. And unfortunately, by analyzing data of more than 200,000 interventions, it could not be shown in this study from Ontario and Canada, with probably more than 100 hospitals participating in that study, that any effect on mortality or reducing complications could be shown. So with this results, it puts, with this result, we have a little bit of uncertainty about what was shown in 2009 and 10, with a clear evidence is there for using checklists, what are reducing complications and deaths. And now in 2014, a group around David Erbach is showing, no, it's not. What to do with this information? If we look deeper into that publication, we will see that the last investigation was just done by taking a checklist without any other measurement, like with a missing comprehensive approach. Only the checklist was provided to these hospitals. No trainings, no awareness increasing about using a checklist, no explanation, no communication about that checklist was additionally done in the hospitals. And this led the authors conclude that if we want to see a beneficial effect of a checklist, we have to train people how to use a checklist. And this is what was a real conclusion in this article published in 2014. So back to you again, back to your questions. I hope that with showing this part, it didn't distract you from that topic and you're still intended to use checklists.
This is great, Saša, because I think I really had that question. So is it the checklist? Is it the implementation? Is it the compliance? And I think you're showing us that compliance matters, but it's not just the checklist. There's something around the checklist, like training and the cultural habits of using it, and probably the good feeling around it. And this, of course, the systems level change. Because we only have about 12 minutes left, Saša, I would propose we carry on. And yes. I would just share with you from the Q&A so far that people are also interested in how does hierarchy and teams behave here, or is the checklist somehow some kind of a mediator there as well? And then there was a suggestion around a daily written plan. So habits that people could take to do your own checklist, it seems. So
I like that suggestion.
I think these were from before, but I just wanted to give you that. And I think as you carry on with your presentation here, we'll just keep the Q&A open so folks can just comment as they go along for the, so that we have their opinions and questions for the final wrap up. So
okay, thank you very much.
Take it from there.
Thank you. I understand very much, and I will take care about the time, trying to still make it understandable for you and not to run over the slides. So if we address medical handovers, we can see that handovers occur in the hospital in many situations, and that we have different layers or different levels where handovers occur and where we are performing handovers between personnel, between situations and the systems. So missing literature about that. I was missing literature about the influence of structured handovers on the patient outcome until 2010 or 2013, where you can find this wonderful work from Amy Starmer from Boston. And she's talking, or she's investigating the influence of implementing handovers, or here in this case, in this study from JAMA published in December 2013, implementing a resident handoff bundle, what's addressing standardized communication and handoff training, verbal mnemonics, new team handover structure, and computerized handoff tools. So as we are talking about checklists and now talking about handovers, what can happen is, or how you can do or structure handovers is with checklists. So we have a maybe pretty similar situation, or a comparable situation where you can use a checklist to structure handovers. And also here, you will see that this is a more holistic approach than just providing a checklist for doing a handover. This would be the very easy situation, what probably absolutely do not influence any outcome. Probably it will even make your handover worse because people are not trained and not informed how to use a checklist. And Amy Starmer and the team use that very holistic or comprehensive approach for improving communication and handovers. And they received, or they have found very interesting results by analyzing over 1,000 patient admissions in a pre-post design and analyzing more than 80 resident reports before and after in pediatric units. So the outcomes were rates of medical errors and preventable adverse events, as we are the whole time talking about them. They were written handoffs who were analyzed, and the physician workflow. So they analyzed the time, what was spent by doing the handovers, and they analyzed the quality of the verbal handoffs. And very interestingly, after the intervention, by providing that holistic approach, medical errors decreased significantly, and also the preventable adverse events. So even more, the data, what was already shown with using and investigating usage of checklists, this study of structuring handovers and offering a training program for handovers is even more showing that medical errors decrease and also the preventable adverse events. What was very interesting, I think there was something like a question about that. What they found is that significant reductions of some categories in written handovers, what were important to the quality, what were contributing to the quality of documents, if they had no computerized tool, 2 of 14 categories were improved, or a reduction of errors were detected. And if they used the computerized tool, in 11 categories, they could detect some improvements. So this is bringing up the theory that, or the idea that maybe digital systems could support our handovers by structuring them and making them even better. Okay, stepping to the next article, and I'm really presenting this data as we usually, and that this is really by intention and not to just cite some articles. I think in my life, what I was even years ago very confident that structured handovers and checklists would improve patient care. Where my uncertainty about that topic was just, is there enough data? What is really showing that it helps, that it proves the decreased mortality rates or errors or not? And by presenting this study from the New England Journal, also conducted by the group around Amy Starmer, even more evidence will be shown to you for using structured handovers. So what they have done in this study, what they have done, analyzing 9 hospitals and implementing a resident handoff program, similar like in the approach before, they have analyzed more than 10,000 patients, applying a checklist called IPASS, what addresses different topics. They found that medical errors and preventable adverse events were significantly reduced. The quality of written and oral handover were improved significantly. And one of the most criticized moments, because this program, if you just listen to the presentation, it seems to be a lot of an investment. And on one side, it is an investment in a hospital, and on the other side, if you have someone who is criticizing this, maybe it could come up that someone is saying, okay, it will probably disrupt the workflow, it will probably prolong the handovers, but it's not. Also shown in this study that the timing of the handoffs is not prolonged and the quality improved. So what else can we wish if we are doing this? And as a conclusion of all these handover studies, what I presented or I will present is that they're really improving the handover and decreasing medical errors. Last but not least, in the short time that is left, a study in 2012 conducted by Gravel et al., what is addressing the handover process between the OR and the intensive care unit. And the study was about transferring patients after pediatric cardiac surgery as a very complex process, and two methods were compared. So they evaluated a verbal handoff as a very common procedure versus a structured handoff with the checklist. And not surprisingly, if you have followed the last minutes, also here, it could be shown that there was a significant degrees of postoperative complication, what was a very hard outcome parameter, more clear than maybe okay, a medical error occurred where we didn't have the direct influence on some patient outcome. But here they could measure that postoperative complications were significantly decreased, and that the number of the early extubations as one of the success markers were increased. So I will directly come to discussion, and I hope that our handovers will not look like this. And I'm pretty happy to receive some questions, and I apologize myself for being over the time, so I had to skip over a little bit of the details.
Well, this is great, Saša. Thank you. And you're all invited to share in the Q&A. I think, Saša, we have a comment there that people do believe that structured checklists will help us do safe handoffs. And so, so I think that's where I'm at. I think just wondering what to do. You know, do I force myself to use IPASS in my setting? Even we've implemented it electronically. And so that's been a nice addition. So it's in the local discussion, but it's really just for when we can avoid a phone call by writing the IPASS. But if I'm doing a handover at rounds or with a specialty that's not using the electronic IPASS, should I be handing a patient the way I do routinely, or should I be using IPASS? Or do you just not, or do we not think it's a personal decision and individual clinicians should not be making this call themselves? It's really at the systems level. What's your take on that?
So my take-home message for you from the experience I have now with reviewing these articles, reading that, comparing it, and working on that topic for a longer time is really the individual approach is totally helpful. And the individual approach by using a checklist could be helpful, and a very important and, it has to integrate itself into the system. So probably it doesn't help. It could even interrupt the process if everyone is using an individual checklist, if it's not adapted to the situation, probably to the individual situation, but not to the situation of the process I'm taking care. And as a physician, doesn't matter in which role, I'm always a part of a process. So I should be, if I'm investing time for implementing checklists, I should contribute to the institution by helping the institution implementing a more holistic approach or a comprehensive approach of using checklists, regardless of if I'm using checklists for handovers or for other procedures.
And let me ask you one final follow-up question, which is, So what is the role of training and simulation in the
Very important.
implementation of checklists?
I can
In your
make
view?
a crucial role as people, as you get the checklist, and if you receive a 124 items checklist, probably not everyone, and I would assume that probably 80% of the people would not be able to use the checklist in a proper and intended way. So what can we do? We as educators, we as the people who are providing simulation and debriefing, I think it's very important to close the loop, to iteratively train people how to use checklists, and also to exclude mistakes and improperly used checklists by simplifying them, making them less complex, and decreasing the resistance level, what usually professionals have.
Well, certainly if your health system uses checklists, I think we should not be designing simulation scenarios that don't have them, because I think
exactly.
that could put us working against a system that's trying to take flight, if you allow me to extend your analogy.
And yeah, exactly. So if you look at what can you learn from other industries, if you look at aviation, if you look at, I had an example where we used this pit stops from cars where teams from Ferrari are working together. If you analyze this situation, 24 people are taking care and maintaining a car in probably 5 seconds. And everything is maintained at the end. And they are following checklists, that's evident. And how can they realize following a checklist in 5 seconds by training? And these people are probably more training to use the checklist than really working in the real environment.
Well, Saša, thank you so much for your time here and your thoughtful review and presentation. For me, it really helped me go deeper into a topic that I too have been thinking about and haven't spent as much time as you exploring, and it certainly opens my eyes to trying to do more in the area. Thank you others who joined here. I invite you to keep in touch with us and connect directly if you're interested in connecting with Saša through his Twitter account or myself or anyone here at CMS, please do so. Also, join us next week for the open forum, Ask Anything. Several of the faculty from CMS and our affiliates will be taking your questions live. Looking forward to that conversation. We have a program in December I'm excited about for the important skill of feedback giving and receiving, entering a feedback conversation. I like that we titled it Up Your Feedback Game, because we always have something to get better at, and it promises to be an interesting situation led by Janice Palaganas, our trusted colleague. And we've got several other programs online in addition to our weekly webinars. So check out our website, join us as you can. We'd love to see you and we'd love to stay connected. For most of you, hope to see you next week. If not on Twitter. In advance, Saša, thank you very much again. And I look forward to talking to you later.
Thank you very much. Thank you for having me here, and bye-bye. Take care.